And it's my pleasure to first of all invite Jim Tsaltis, who is an infertility specialist and a laparoscopic surgeon at Melbourne IVF.
Karen, thank you, and I would like to thank the organising committee for their very kind invitation to speak to you on a Saturday morning, and it was certainly a very cold start to Saturday in Melbourne, but it's certainly a lot nicer driving here this morning, and certainly a testament to what is a great conference to have so many people here on a Saturday. I was thinking when I was asked to present this lecture that how to particularly approach the lecture, and rather than just focusing purely on fertility, I would like to sort of talk a little bit about that, but also talk about endometriosis and some of the concerns I have, a little bit about awareness, because it really is a major health issue for women, and it tends to be brushed off because, as we know, women go, young girls go, young women go along to and they're told they've got terrible periods and they're really struggling, and firstly their family tells them they shouldn't worry, because it was happened to myself and to grandma and we had bad periods, and then unfortunately they go along to their general practitioner, and if their general practitioner hasn't got an interest in women's health, they'll tell them again not to worry and try many different regimes and not really think about endometriosis. And unfortunately, even in 2012, the average number of years from the time that you actually have your first symptoms to the time that your diagnosis is made is 8.7 years worldwide. So that's still a staggering statistic. When I first thought about that statistic, it was 9.5 years. That was 15 years ago, and unfortunately we've only got it down by 7 months. So, as you know, endometriosis is the presence of endometrial tissue outside of the endometrium, and when I was a boy it was glands and stroma, but now it is glands and or stroma, so ectopic endometrium outside of the uterus, and the most common areas it involves are the pelvis, within the abdominal cavity, and obviously can be in other organs. And recently I have had a run of patients with extra abdominal endometriosis. I've had one patient with endometriosis in the nose, one patient endometriosis in the lung, and one endometriosis in the anterior chest wall. Now, everybody always remembers the very rare things, but remember nearly always, in 99.9999% of cases, it is in the pelvis. The two most common sites are the ovaries and the uterosacral ligaments. And if you actually look at what the burden of this disease is on our community, in that women who have endometriosis will on average lose 11 hours of work per week on a global scale. So it really impacts it. It costs our communities worldwide billions upon billions of dollars, separately to the issue of a major effect on women's health, their quality of life, with their pain and their fertility. So just a couple of little pictures, and I was going to think about putting together videos, but in 20 minutes I thought that would take up too much time, and we've got looking at minimal to mild endometriosis. Do we have a pointer, Karen? No, that's right. Oh, the mouse. Okay, sorry. Well, it's too complex. A bit old school using a pointer. I almost bought a carousel. With slides. And so we've got the uterus here, left ovary, and we've got the uterosacral ligaments here. So on the right pelvic side wall, you can see there's endometriosis, and the ureter will be close by. And here on the left uterosacral ligament, coming down across the vaginal and prerectal fat, you've got endometriosis, and you get a closer view of the endometriosis. And this is minimal to mild endometriosis. And the important thing to know is that the degree of pain that we hear from our patients is unrelated to the degree of their endometriosis. So you can have severe pain and mild endometriosis, and you can have quite significant endometriosis but have minimal pain. So it's not a great correlation with disease. And then looking at some moderate to severe disease, and I put this one up because when you first look at this you wonder what is going on in the pelvis. And here you have a uterus, and you can see all the inflammatory exudate and adhesions caused by long-standing endometriosis. There's no separation of plane. This is the colon, and this patient has the bowel stuck up, the sigmoid and the rectum stuck to the back of the uterus. And over here, on the left-hand side, where you would normally see the left ovary, there is a mass which is a hydrosalpinx, so swelling of the tube, and the ovary somewhere underneath there with an endometrioma. So this patient actually had severe period pain and actually had been trying to conceive for 2 years with major distortion of their pelvic anatomy. When we talk about the classification of endometriosis, the classification system is not the most reliable method, but at the moment we need to use one uniform method, and this is the ASRM, which is the American Society of Reproductive Medicine classification, which was initially brought up in 1985 and has been modified. And we do use this when we're discussing endometriosis so we can all communicate with each other about the degree of endometriosis, but it was developed to look at infertility in endometriosis, that the more significant you had your endometriosis, the more likely you were to have problems with your fertility. And that is probably the one correlation that exists, severity and degree of infertility. And you were then asked to look at the different stages, and there were diagrams to give you an example of having a little bit of uterine or adenomyosis, uterosacral, then you start to have a bit of ovarian, a little bit of uterine, uterosacral, a few adhesions. I want you to just focus on these two because I'm going to come back to those two diagrams shortly. And then you had stage 3 and stage 4 endometriosis, which is moderate or severe. But the problem with this classification is that when we talk about severe, that it doesn't actually incorporate colorectal endometriosis, deep vaginal endometriosis. It's very difficult to put that into that classification. So you do call that disease stage 4 severe endometriosis, but it's then important to actually outline your findings and actually describe your clinical findings both at examination and also at laparoscopy and ultrasound. So if we look at the symptoms of endometriosis, the main symptoms, just think about them along the right-hand side here. Significant dysmenorrhea. It often starts just with the period, but then it can occur from mid-cycle with ovulation pain, and then you can have pain leading up to and worsening with your period. Pain in emptying your bladder, so dysuria, particularly at the time of your period. One of the areas that I see a lot, which is severe dyschezia, and severe dyschezia is severe bowel pain or pain in the rectum, deep in the pelvis when you actually move your bowels. And when it's associated with rectal endometriosis, it occurs with your periods. And sometimes it can be so severe the patients actually have difficulty moving their bowels. And then obviously the other thing that we see is problems with deep dyspareunia and intercourse, particularly when there's uterosacral and vaginal involvement with deep penetration. And then obviously there's other symptoms, and the pain can become initially cyclical, but then can become chronic in that the women will describe it, they feel that they've got their period the entire time, and then it gets much worse, their pain gets much worse with their actual period. And we know that 30 to 40% of women with infertility, if not more, will have endometriosis as part of their laparoscopic findings. And then you can have abnormal menstrual bleeding, particularly premenstrual spotting, which tends to be associated with endometriosis and in particular adenomyosis. And as I mentioned, that there are no symptoms. And if you look at the Jean Hale's website, one of my colleagues, Susan Evans, had a particular interest in endometriosis education, actually published a book on endometriosis, but now it's an e-booklet which your patients can access through the website, and she's made it freely available to the community in Australia. And remember, just to think about those points of the most common symptoms: severe dysmenorrhea, deep dyspareunia, infertility, and chronic pelvic pain. And really that's when you've got to think about, has this patient got endometriosis? And you don't have to have all 4, you can have 1, 2 or 3 of these particular symptoms. Now, are we seeing an increased prevalence in endometriosis? And we were thinking with my fellows about why there may be, and I asked the fellows to give me their theories as to why there is increasing what we think is an increasing prevalence in endometriosis. Is that we have more and more ovulations because we have fewer children and we're breastfeeding for less time? Have we gone from being a forager to a farmer, so we no longer have to hunt for our food and we're not as thin as we were? We know that the thinner you are, you can control your pain better due to endorphin release. So exercise is the one positive thing that our patients can do. So also obesity and the increase in estrogen conversion in the periphery, and therefore feeding your endometriosis. Obviously fewer children. But is it that we're better at diagnosis? We're now thinking about it more. We are now very good at laparoscopy, and it's certainly the gold standard of treatment amongst gynaecologists. And also ultrasound is playing an increasing role, particularly in Australia, of deep infiltrative disease. Or is it actually just exactly the same, the prevalence, and I don't have the answer, and that we are just better at diagnosing it and we're thinking about it a little bit more. And if you look at the statistics, it's not as clear cut yet. If we look now at fertility, and I'll spend the last few minutes of my talk talking about this, looking at some of the mechanisms of how endometriosis may affect your fertility. This was recently published in The Lancet out of Charles Sopron's unit in Paris, which does a lot of work on deep infiltrative endometriosis, and we look at the effect on the pelvic cavity in that there are inflammatory changes in the peritoneal fluid and there's increases in macrophages, and we know that just having endometriosis will cause increased inflammation in the pelvis, and it can affect the ovarian-sperm interaction, therefore fertilisation and subsequent implantation. And I think that we can't forget that adenomyosis may have a role in implantation failure and problems related to fertility. There was one good paper out of Germany looking at mild endometriosis and infertility and looking at sperm migration and then implantation, and the worse your adenomyosis was within the uterus, that you actually had a lower implantation and poorer sperm migration. I'm just going to talk about the sperm migration because I thought this was a fascinating experiment, in that they actually used tiny beads that were coated with immunofluorescence, and they could track them, and they created the beads to be the size of sperm. And so they put them into the back of the vagina at different phases of the cycle, and they found that as you came closer to ovulation, normally the sperm would go equally up both fallopian tubes, but as you got closer to ovulation, you actually had 2/3 to 3/4 of the sperm going to the ovulatory side of the pelvis, so it would go up that tube. And obviously there must be some internal communication that we have no idea as to why that happens, but as your adenomyosis got worse, then the sperm just went everywhere. They just could not work out where to go. Now they could just say that's male drivers anyway, but I thought that was a fascinating experiment, and it did, and it's been the one good piece of evidence about adenomyosis and the impact. Then obviously the uterus, we talked about different effects within the uterus, resistance to progesterones and pre-menstrual bleeding can affect implantation, and then ovaries, we know that if you've got significant endometriosis, it will actually affect your ovarian reserve, and not only will the endometriomas affect the ability of the ovary to work, but then we have to operate on them, and we also impact on the ovarian reserve and can damage the ovaries, and I'll talk about a little bit how we take care in doing that. And then obviously when you've got endometriomas, you don't respond as well to ovarian hyperstimulation in IVF. So have we come a long way? And I've put lots of question marks with the management of fertility and endometriosis. And my fellow insisted that I put the next slide because it actually showed that we don't like to talk about periods, we don't like to talk about sex, we don't like to talk about endometriosis. And in 50 years, this is on the right-hand side, the first advertisement ever to show a drop of blood in 2010 on a pad or tampon ad. And so it is, I said to Marilla, why have you put this slide there? And then she explained the significance of this, and I thought that we just like to bury our heads in our community, and we like to show all these lifestyle related issues to your tampons and pad usage, but we don't actually talk about why you really use pads and tampons and how this particularly endometriosis and the pain associated with your periods can affect your quality of life. We also have seen an increase in the Medline citations in endometriosis, back from less than just on 200 papers back in 1980 to now over 1,800 papers on endometriosis. So that means that there's more research. And the research is not just on surgery, but more importantly on pathogenesis, pathophysiology, underlying better ways of diagnosing disease, ultrasound, markers, etc. So that's a very, very positive thing, and it's a worldwide thing, and it's involving scientists. And if you look at the annual the World Endometriosis Society meeting, which runs every 2.5 to 3 years, it was a meeting that had 400 people, and now you've got almost 1,500 people attending, and most of those are scientists attending those meetings. This is a particular, I'm just going to direct you to the article here by Dominic de Ziegler in Lancet and Charles Sopron, just about some thoughts about if you have a patient with infertility and known endometriosis, about an algorithm of how to think about it, particularly if there are endometriomas, and to look at the infertility workup once you have endometriosis, particularly endometriomas, to look at the ovarian reserve. And if your ovarian reserve is compromised, there is an argument to consider emergency IVF, to think about freezing eggs or even thinking about creating embryos. Then if the ovarian reserve is normal, obviously look at the semen analysis. As that part of assessment, look at the fallopian tubes, and then consider either surgery followed by natural conception. But if there are other factors such as abnormal semen analysis, problems such as pelvic plane hydrosalpinx, it will actually help you think out whether you should be just looking at moving straight onto IVF, whether you should be looking at surgery prior to IVF, or whether you should be looking at GnRH analogues for 3 months prior to IVF treatment. And so really what I got from this slide was that you can't just follow a set algorithm as they have in Dominic Ziegler, but you need to individualise the treatment and you need to think about all these potential issues that may arise in the couple. So if we look at surgery for endometriosis, we went from open surgery, and the vast majority now of surgery is performed laparoscopically. You can either look at definitive surgery, so if a woman has completed her family and desires no more children, that we then look at, we may think about definitive surgery, but then certainly what we're talking about is conservative fertility, sparing surgery, and when we talk about the surgery, we should no longer be talking about laser surgery or diathermy. We should be talking about excisional surgery, and that we use electrosurgery, but there are other methods of energy. And we talk about the cysts, and we should think about excising the cysts rather than draining them, and then obviously about the management of bowel and then tubal disease. And really the whole idea is to normalise the anatomy, including adhesiolysis, to try and improve the fertility for the patients. Because IVF is a great technology, but it is expensive. It's not able to be accessed by every single woman in every part of the world. You have to think about the cost of IVF and the access of IVF. And there are individuals who would prefer to look at more natural options, and therefore surgery should still be considered an option for their treatment. So if we just summarise that, you want to normalise the anatomy, you want to identify the endometriosis, you want to remove the endometriosis and subsequently enhance the fertility. And then when you're managing endometriomas, you want to watch your technique. You want to minimise diathermy whilst you're actually controlling bleeding within the endometrioma to try and reduce the amount of damage that you're performing on that you've actually creating within the ovary, because the ovary is already damaged from the endometriosis. You want to create as little damage as you possibly can, and so therefore minimise your diathermy, and we use a lot more suturing now to control the bleeding within the ovary and to close it, and certainly with the use of AMH, or antimalarial hormone, which is produced by the beta follicular cells within the actual ovary. You have an outstanding measure now, a very reliable measure of ovarian reserve, and we now use it pre and post-operatively to actually assess ovarian reserve and help us make a decision about when to move on to IVF, and really it's about the appropriate timing, just with a very simple principle that if you actually operate on a patient that you remove their endometriosis, you would then look at 6 months. If you're going to go to the surgery, you need to then look at 6 months of trying to conceive spontaneously. You presume that the male partner's got normal sperm before looking at IVF, but there'll obviously be some patients, particularly if their AMH is significantly compromised, that you may actually look at IVF earlier than that. And what is the evidence for surgery? And going back to our initial minimal to mild disease, stage 1 and 2 disease has been the only group of disease which has undergone a randomised control study where they randomised, there's 2 studies, a Canadian study and an Italian study, where they randomised surgery with excision of endometriosis for the surgery and diagnosis only, and by removing the endometriosis, you actually improve the fertility over the next 6 to 12 months. This is strong grade 1 evidence, so we would advocate that for level 1-2 disease that you should remove the endometriosis. However, to actually have 1 pregnancy, you do need to do 10 laparoscopies. So we've got to think about that, and also the patient need to be aware of that particular outcome. And again, moderate to severe, there is no great evidence to support one method over the other, except when you've got endometriomas, and there's excellent randomised control studies which actually show that you should excise the endometriosis, not drain them and burn the inside, and excisional surgery significantly improves pregnancy rates in the 6 months following the surgery. And again, I talked about ovarian reserve and minimising damage. And when you talk about stage 4 disease, surgery should be offered as an option to IVF. However, there is no good evidence for you if the patient asks you what's better, IVF or surgery. We have no data to say one is better over the other. I think the recommendations depend on the age of the woman, any male factors, tubal factors, the size of the endometrioma associated with the rectovaginal disease, and obviously their ovarian reserve. And again, you really need to individualise the treatment. And also on the other side, that we should be considering surgery for patients who've got severe endometriosis and have undergone a number of unsuccessful IVF cycles, that we really should be thinking about surgery in that age group. So really, it is a global approach to the problem, and I've run a little over time, but this is an endometriosis fertility index that once you've done your surgery, this has been validated by David Adamson at Yale University, you can actually quantify what the pelvis looks like immediately after the surgery. And then at this bottom graph, it actually gives you, depending on the findings, and these are very clearly set out here, that if you have these particular findings in the pelvis, so amount of damage, tubal openings, what the fimbriae look like, that your chance of spontaneous pregnancy, and it will help you actually move your patients forward to IVF treatment. So I just want to conclude by making you just thinking about endometriosis. It's very, very important. You need to consider the diagnosis. We need to help these young women, and many of them suffer for a long, long time. Laparoscopy is still the gold standard. Really, where we fail and we need to do better is increasing awareness, and the Gene House does an enormous amount of work in this area, and we need to individualise the infertility treatment and really be up to date with the evidence. So thank you very much for your attention.